Hi, welcome back. It's Gerald Major, and I'm here with Dr. Mercedes Chen. And we're going to talk a little bit about, I'll let you introduce yourself, but we're here from the 2019 Canadian Rheumatology Association Allied Health Professionals Annual Scientific Meeting in lovely Montreal. So why don't you take an opportunity to introduce yourself, let us know what you've been doing here at the CRA this week, and go from there.
All right. Well, thanks, Joe, for this opportunity. So I'm Mercedes Chen. I'm a pediatric rheumatologist at BC Children's Hospital in Vancouver. So I see children with rheumatic diseases such as juvenile arthritis, pediatric lupus, vasculitis, and autoinflammatory diseases. And I'm here at the CRA to first connect with my colleagues, to get updated, and then also to do two presentations. So last night I spoke a little bit about competency-based medical education, which is a new way of training doctors in Canada. It's a bit of an educational movement that's just started in the last couple of years in Canada. And then I'll also be conducting a workshop on global health issues in pediatric rheumatology tomorrow.
So what are the key issues from each one, or what are the key messages?
Right, so for competency-based medical education, this is going to be a bit of a shift in how we believe we should be training doctors. We always, in our system right now, we feel after 2, 3, 4 years in this training program, you should automatically be qualified or have all the skills needed, we assume, to practice. So it's time-based, but the outcomes can be variable. With competency-based medical education, right now we're going to be setting a whole bunch of competencies such as skills, abilities, observable performance outcomes that we're hoping trainees are going to be able to meet. And recognizing that maybe some people will meet these sooner rather than later in their training continuum. And so we're really looking to make sure that when doctors graduate from their residency programs, that they can fulfill a certain amount of skills or have a specific skill set.
So the direct impact to patients is likely better care, and
We hope so. And a part of that will also be because this is going to require that we do a lot more direct observation of our students when we're teaching them, so that we can give them active, constructive feedback. We can coach them through the various scenarios that they may not be able to complete successfully, say on the first attempt. But that's the whole point of residency. It's to learn, it's to grow in becoming a physician, and the best way to do that is by having an expert watch you and guide you along the way.
The theme this year for the CRA is building bridges. So what does that mean to you in your work?
So for me in my work, building bridges has always been something really important. I really believe in the power of connections. And in my career, I've been very fortunate to have people who've wanted to bridge international, local, national gaps with me, really to further the movement of pediatric rheumatology. So whether it's, say, bringing people together who have specific interests or expertise to further a specific movement or to learn more about a specific disease, or bringing expertise and collaborating with people in other countries where rheumatology may not be as prominent. That's kind of what building bridges means to me. And for me, in a lot of my international work, because I do a lot of teaching overseas, that's been kind of one of the most valuable bridges in my life that I've been trying to build and continue to build.
It seems, just in my observations over the last 3 years or so, that it seems that Canada's venturing outside of Canada quite more often. So can you give a perspective on that?
Yeah, so the world is getting smaller. It is much easier for people to travel with technology. We're able to connect with colleagues all over the world with a click of a mouse. And so I think it's really important for us to be aware of what's going on in different parts of the world, and also to learn from what's going on in other parts of the world. So certainly I know there's a number of rheumatologists in Canada who regularly spend time in Africa and Asia, South America, working with colleagues there to strengthen rheumatology practice all over the world. And certainly for me, I've been very fortunate to spend time in Africa and Asia as well, working with colleagues there. We routinely have trainees who come from different parts of the world to train in Canada, because we know that our training programs are very, very strong. And in return, often we have trainees who spend time in other countries as well, to also learn from them and just to see what practice is like in a different part of the world, and to hopefully enrich their own experience and understanding of how to work with patients from diverse backgrounds.
And I mean, we are such a diverse country, so I mean, it makes absolute sense. So not only the collaboration kind of internationally, from a patient perspective, really disease has no borders, right? There's different policies and different cultures and stuff, and I think there's a ton of value in sharing both ways. Give us an example of something that you've brought back internationally and you've either implemented, or if it's changed your line of thinking.
Yeah, so I think, given the fact that there's a lot of migration now and a lot of travel back and forth from different countries, one of the biggest things that comes with that are people who come from countries who have, different, and what we call endemic diseases, or perhaps like infections that are much more prevalent in certain parts of the world. And so I know sometimes for my patients, when they come from specific parts of the world, maybe just instead of thinking about the usual infections that might cause arthritis, here I have to think a bit more broadly. I have to think about tropical diseases. In recent years, the Zika virus has made a lot of headlines. That can be a cause of joint pain. For my patients who do a lot of traveling to areas where tuberculosis is prevalent, I now am more aware that, when they come back, maybe I need to screen for that. That's something that I wouldn't usually think about if I just had a patient, say, going to the US. Other things to consider would be some of my patients from areas of the world where HIV is more prevalent. I need to think about that before I start immune suppressing therapy. And even though I work with children, unfortunately, disease, as you say, has no borders. It has no age limit sometimes. And so it's just really given me pause in terms of breaking down some of the preconceived notions or stereotypes that I think may exist, like in terms of disease, or and sometimes it's actually made me realize, I do need to think about these things, even though we don't usually associate that with practice in Canada.
Very interesting. So from a pediatric perspective, I know that last year I did some interviews, and finally the area has got some funding behind it that it so desperately needed. So what is it that we are going to look forward to in the next 5 years in pediatric care?
I think in the next 5 years in pediatric care, we're going to be looking at more of the origins of disease. I think now with the technology that's available, mapping genes is going to be something that we're going to look at more, and hopefully getting a sense of the biological basis of some of the diseases that we see. Personalized medicine, that kind of goes in line with that, I think is also going to be a lot more talked about, if not already. And when you think about it, it's personalizing medicine for children. Like children, it's so much more complex, and they're so much more complex than adults, because not only are they people, but they're people at different stages of development. And so there's just that extra aspect of complexity.
I mean, at 14 years old, I had trouble communicating my disease. I had problems understanding it. So I can only imagine the younger you get, the more difficult it is to communicate. So what are some of the things that are different that you really need to be aware of when you're talking pediatrics versus adult?
So I think the biggest thing is that children do not complain of pain. Or that sometimes they do not always complain of pain. And parts of the reasons why that might be is because maybe they've always had it, and so they don't realize that that's what they're feeling, or they don't want to tell someone because they know, they might get in trouble, they may need a needle, they may have to go to the hospital, they may see a doctor. And then other times they're a child, they want to have fun, they want to play, they don't want to be taken away from, the soccer field or be told they can't do X or Y. And so I think one of the biggest misconceptions about childhood rheumatic disease is that it has to be associated with pain. And we know that that's not the case. And in fact, about a quarter of all kids with juvenile arthritis don't complain of pain.
Wow. Huh. So from a from a juvenile perspective, outside of so personalized medicine, I think is just so important for every patient, and I can imagine more so there. But there was concepts last year that we were talking about diagnosing early in children, treating early, and possibilities of remission early. Is that still something that's talked about and thought
I
of?
think that's something that is always going to be a goal of ours, and a big reason behind that is because we know now with the current medications that are available is that remission is possible, and having the highest quality of life is a goal, and it can become a reality for many of our patients. And that might mean that for some, we do treat, or actually for many, we do try to treat aggressively and early, because we do know that that's associated with better outcomes, not just functionally, but also at the biological level, less joint damage. And that it's huge when you're talking about a 4-year-old who's hopefully going to have, many more years of life ahead of him or her.
So do we have, is there, where was he going with this? Is there the families that come with children? What is done around how to help everyone kind of understand and support and deal in the right way?
That's a great question. So in pediatrics, we are incredibly fortunate in that almost at every academic center in Canada where we have pediatric rheumatology, we have a multidisciplinary care team. And so that doesn't just include the physicians and rheumatologists, but we have specialized rheumatology nurses, we have physiotherapists, we have occupational therapists, we have access to dietitians, to social workers, and we recognize that understanding what is a chronic disease is not just going to take one visit, it's going to take a whole lifetime to understand. And so the whole team is there to work with families to help better understand their disease. And because these diseases they're not static, we recognize that at any given visit we may have to revisit our understanding of what's going on as new medications and innovations are available to us. We have to be able to disclose these to our families and discuss what are options that are available to treat. And so with this multidisciplinary team, where each member has different strengths of their understanding of disease and how it affects a child's life, I feel that we're able to really make a concerted effort to help families and patients and children understand what's going on, which is not easy.
No, it's definitely not. It's not easy for adults, so no. I can only imagine. Do you have any questions from the audience, Anita?
Yes. Do you have any tips for children living with juvenile arthritis as well? How can parents of children recognize that their child may have arthritis? Because you were mentioning, the children might not necessarily say they're in pain because they don't recognize that.
Right. So the easiest would be if a child did complain of pain, especially in a joint, looking to see if it's swollen, looking to see if it's warm. Sometimes that is difficult for someone to pick up if they're not a medical professional. But if you're concerned that your child may have arthritis and that they're limping, or one of their joints are swollen, or maybe say they used to be right-handed but now they're left-handed, or they were walking and now they've gone back to crawling, bring them to see their GP or their pediatrician. And this primary care network that we have in Canada, they're all connected and plugged in with local academic pediatric rheumatology centers, so they can always get on the phone and call us, and if we think there's something is concerning, then we'll try to see them as soon as we can.
And what are some of the challenges of working in pediatric rheumatology?
So I think certainly there's many. Well, one is working with children. It can sometimes be challenging. It's not for everyone. And so learning to work with kids sometimes who can't quite communicate with you, I think that would be the biggest challenge. Having them, asking them to do a specific command for you, like when you're doing an exam, can also be challenging, but that's where play becomes very important and becomes critical actually in doing a physical exam, and also observation, because when you're playing with someone, you can actually see how people are moving without intentionally saying, oh, I want you to move this so I can see if it's not working properly. You can just play and ask a child to look up at the ceiling or look down at their toes, or bring a toy around the room and see how they interact. And I think there's a lot to be said about the power of observation and how much you can get just by looking at a child interact with their family and surroundings.
And you participated in the great debate at the CRA. It pretty much talked about the old way of teaching versus the competency-based medical education. What are the key differences between those two?
So I was saying to Gerald earlier, like one of the big differences is that with competency-based medical education, we're teaching with targeted outcomes in mind, and really hoping, or with the goal of seeing that trainees actually are completing these or they're reaching these outcomes to our satisfaction before we say you can graduate. And so it's going to be maybe faster for some to reach these outcomes. It might be longer for some to reach these outcomes. So instead of saying, okay, we're going to be in residency for 2 years and you're going to become a rheumatologist at the end of that, we're saying, okay, these are the outcomes we want you to be able to meet. For some people, it might take 18 months. For others, it might take 20. For some, it might take 26. But at least at the end of that time, we know that they're able to come out with a specific set of skills that they've mastered to a certain level.
Well, it's been a pleasure having you and meeting you today, and I appreciate all your work within this population, and congratulations on your achievements, and good luck
Thank you.
with everything else.
Thank you for
Thank you
having
so
me.
much.